Separate yourself from other people. If your friends say, come round for a cup of tea, I'm feeling fine, let's have a drink, say no. If your friends say, can I come round for a beer on Friday night like I normally do? Honestly, I haven't been infected, I haven't been anywhere near the disease. The answer's no. We have to change social norms. Obviously, hugging, kissing, shaking hands, completely out of the question for the foreseeable future. We have to be meticulous with our hand hygiene after we've been out. We have to think about contaminated clothes and surfaces, thoroughly washing of the hands, proper clinical washing of the hands, like you've got lots of videos on that now. Meticulous hygiene. And also, if you have to use a public toilet, be particularly meticulous with hygiene there. You know, we have to remember that this virus can only reproduce inside human cells. And the only way it's going to get into an uninfected person's human cells if we are exposed to the virus. If we are physically separated by space and cleanliness from that virus, we won't get it. And that will break the chain of transmission, and the R0 will go down below 1 and the number of cases will start to recede. But this is for everyone. So we're not saying, oh, I'll just behave normally while I'm waiting for the scientists to make a vaccine. No, absolutely everyone in the world is intrinsically involved in this fight against the virus. They have to be. This is for everyone. Anyone watching this, you're involved.
The world is changing. Inspiration is everywhere. It has never been so easy to connect, share, and bring people together. We're learning from others and finding the best in ourselves. Challenging our beliefs, sharing our vulnerability, overcoming our fears, transforming ourselves so we can transform the world. How far can we go?
This is London Real. I am Brian Rose. My guest today is... Welcome to a special edition of London Real. I am Brian Rose. My guest today is Dr. John Campbell, the author and academic known for providing expert advice and information on the COVID-19 pandemic based on his 40-plus years of professional experience. John's mission is to educate the public about the coronavirus pandemic in order to aid intelligent and informed decision-making. Over the past few months, his YouTube channel has gained millions of views as his audience looks for practical, down-to-earth, and real-world advice to stay alive during this terrible crisis. Dr. Campbell, welcome to London Real.
Thank you very much, Brian. Good to be here.
Super excited to have you here, John. I've got so many questions. I just kind of wanted to bring people up to the state of the union right now, and then I really want to get inside your head as far as what you see going on in the world right now. According to a video you released about 45 minutes ago, this is kind of where we're at as far as numbers, give or take a few. The current infected number of people worldwide is right around 446,000. The current death number is just under 20,000, and the number of recovered people is 112,000. Currently here in the UK, we are under lockdown. Prince Charles has just tested positive for the COVID virus, and of course, Europe and America are all in lockdown. We found out today that India's 1.3 billion population has now been placed on lockdown. It looks like the New York City metro area now has an alarming 7% of the global cases. The global economy is tanking with markets down over 30% and an all but certain global recession coming. We're pretty certain there will not be enough ventilators for the first wave of victims in the UK or the USA, although I want to get your thoughts too. And now here in the UK, I don't know about for you, John, but for me, it feels like we're watching a train crash in slow motion, knowing that there's a certain amount of death that might be coming. John, you've been talking about this for months. You were making videos before the media was talking about this, and you've watched it unfold in real time with your videos putting out. I was wondering, John, if you could tell us about what's happening from your perspective, and what do you think is going to happen in the coming weeks?
I started looking at this back in January, Brian, and I was looking at a little bit of the background science, the transmissibility of the virus. I was looking at the way that international travel was not really shut down, that things seemed to be going on almost as normal outside the Wuhan, Hubei area. And that kind of concerned me. But then when I started seeing the reaction of the Chinese, that really concerned me, because the Chinese don't tend to overreact to things. And the fact these three things kind of went together, and I thought, just a minute, this is a problem here. So I was quite suspicious then that this was going to spread. And it has been roughly spreading out to roughly where we thought it would be. Now, where we're at now is the curves are increasing. The total number of people that are infected is increasing. Now, of course, you've got to remember that figure you read out, that well over 400,000 figure, is the people that have been diagnosed. So they're the people that have been diagnosed with the antigen testing. Now, the antigen is actually the virus itself. So the current tests are testing for the presence of the virus itself. And some of those were also clinically diagnosed by Chinese clinicians, Chinese nurses and doctors, who are quite experienced at it. But we can assume that the real infected number is way higher than that.
10 times more, maybe.
Sorry?
Maybe 10 times more.
It's very hard to say. I mean, if we be more specific, in my country, I can't remember what it is now. It's about 4,500 or something confirmed cases. But a couple of weeks ago, the chief medical officer said the real number is probably 10 times that, or even 20 times that. So that's the opinion of my chief medical officer. So, I mean, you're right. We probably could put a naught on the end of that. But of course, at the moment, we simply don't know. There's so many things we don't know. This is a novel virus. It hasn't circulated in human beings before. It's zoonotic. It's come from animals, and we are learning about the way that this virus interacts with its human host as we go along. The problem is the learning that we are currently going through now is remarkably expensive, because people are getting sick and people are dying as we learn. But basically, it seems that the number of cases is increasing. So 100,000 cases in the first roughly 65 days, then another 100,000 in the next 11 days, then another 100,000 just in the next few days after that. The increase in number of cases is quite exponential at the moment.
Right, that really shows that exponential increase, which we know happens when you have that N0 number. Well, anything over 1, I guess, but and we think this N0 is somewhere between 2 and 3. Is that right?
The R0 is a difficult concept, Brian, because the R0 is not some intrinsic property of the virus. It's not as if the viral biochemistry and the physiological interactions of the virus with the human host gives rise to a specific R0. The R0 is actually the average number of cases that any one infected person will infect. And of course,
it reflects how contagious it is, right? Just for anyone that doesn't know.
It's determined by two factors. It's determined by the transmissibility and contagious nature of the virus, but it's also determined by the opportunities that the virus is given to jump from person to person. And of course, if we're physically separated and our breath and droplet infections are physically separated, then the virus can't spread. So the fact that the number of cases went down in China would mean that they got the R0 below 1. Whereas the fact that the cases grossly increased in Italy, for example, means that their R0 was way greater than 1, and it was probably 2 or 3. In the early stages in China, the R0 was estimated to be 2.6. So if we go with an R0 of around about 2.6, that means on average, every infected person is going to infect another 2.6 people. But there again, if people are crowding together on subway trains or buses, or they're all together breathing each other's air in aeroplanes, then the R0 could easily increase, and it could be 3.
Wow, and that's why we think New York City has such a high number of infected, because we think that population density maybe increased that R0.
I think in New York there was 2 factors really. The first is you have an awful lot of international travelers. I understand you have quite a large Italian-American population, so you had people coming in to do business from all over the world. So there's probably some early cases from China, and probably some early cases from Italy. And also, as well as that, non-nationals of those countries who traveled to New York. So they probably seeded it. And then there was probably quite a bit of almost underground transmission that went on for some time before the problem was detected, because the testing regimes in the States have been pretty slow to get going. So it's reasonable to assume that community spread, it's likely community spread was already established in New York and probably New York State before the first cases were officially diagnosed. And that allowed a certain momentum to build up. So I think that's probably one reason why there's a lot of cases. And as you rightly say, the lifestyle of people are crowded into subways, people are crowded into buses. There's a lot of fairly close proximity in offices. And as well as that, of course, it's pretty cold there now. So people tend to keep the windows closed. So that means that they're inside buildings and they're breathing each other's air, and virtually you've got pretty well guaranteed spread. There's also quite strong indications that the virus is spread in air conditioning and things like that. I mean, that came from the initial work from the Diamond Princess, the cruise ship that was quarantined in Yokohama, and ended up with an awful lot of positive people on the ship who we were assuming were not infected at the start of the quarantine period.
Okay, so that means airplanes are just as bad for recirculating. Brian? So airplanes as well, recirculating air. Those are going to be places that
airplanes in form of they have excellent filtering systems. But of course, that's not going to filter out the air from the person next to you.
Next to you, right? Okay.
Or the person in front of you, or immediately behind you, or the person walking to the toilet down the row. You know, it's basically it's a fairly closed environment. And I know I often get chest infections after flights. Right. I'm sure you have.
I've got so many questions. I was watching the daily press conferences from President Trump in America, and he's got quite a interesting group of advisors behind him, and occasionally they'll get up and talk. And there's a woman, I forgot her name, that got up 2 days ago and said that the cases of mortality so far, it's 1% under the age of 50. And that number really struck out to me. And then she said the ones that are over 50, many of those had at least 3 pre-existing conditions, some type of respiratory condition, et cetera, et cetera. First of all, do those sound accurate to you? And second of all, you know, what does that mean? I know you released a video recently that walked through various things, male, female, age, even body fat percentage as far as who is potentially susceptible to this disease. What have you seen so far, and do those numbers make sense to you?
Yeah, there's basically 2 sets of data we've got on this. There's the first 72,000 cases were reported on by the Chinese Center for Disease Control. So there's quite a lot of epidemiological data from China. And also there's some early epidemiological data from Italy. Now, the data from both of those countries was I think you'd have to say broadly consistent between the epidemiology of serious cases in those countries. So the case fatality rate is the number of people basically that die per 100 that are infected. It's a percentage. So my medical officer is currently estimating it might pan out at about 1% as an overall. Now, it's very hard to estimate this because suppose there was 10 people died from 100 that were diagnosed. Then that will give you a case fatality ratio of 10%. But for that 100 that were officially diagnosed, there could be 900 patients who had the disease but weren't diagnosed and had a very mild form of the disease. So instead of giving you 10 in 100 deaths, that will give you 10 in 1,000 deaths. So this is the great hope in this, that we are seriously underdiagnosing the overall infected numbers and therefore greatly overestimating the death rate. But it's certainly true from all the data we have so far that the probability of death increases with increasing age. So there are very, very few children seem to have died from this, which is such a reason to be thankful for that. And very few young people are dying from it. Now, we do hear in the news of young people who were young previously fit, who have got severe disease, and some who have tragically died as a result of this. But if we're taking whole population studies, it remains true from all the data that we have now that the probability of death increases with increasing age. So as you say, around about 50, the chances are about 1%. I'm 62, so in my age group, the 60 to 70 age group, the chances of case fatality are about 3.6% in my age group. When you go on to 70s and 80s and older, the probability greatly increases. So people over 80, it's something like a 14-15% case fatality rate. People over the age of 90, it's getting on for a 25% case fatality rate.
Wow, and that's just immunity decreases over time. And I read somewhere it doesn't matter how healthy or fit you are; it's a factor of age.
Again, there's two views on this at the moment. One is that the main risk factor is age itself, and as you rightly say, Brian, immunity does reduce with age. There's no question about that. We know that from antibody studies where older people will respond to vaccination, for example, not as vigorously as younger people will. But as well as that, as people get older, they are more likely to have comorbidities. So a person is more likely to have another illness when he's 60 than when he's 30. Thankfully, the middle years of life are usually fairly healthy years. And as we get older, especially in Western societies and increasingly in all world societies now, there's more diabetes mellitus type 2. And basically, the prevalence of diabetes mellitus around the world is horrendous now. It's about 8 or 9%. A lot of people have got diabetes type 2. There's increasing incidence of cardiovascular disease. There's increasing incidence of all the respiratory diseases, such as chronic obstructive pulmonary disease with bronchitis and emphysema. And there's also, as you say, with age, there's increasing probability of immunocompromise. But there can be reduced immunity through specific diseases or through medication. And the other disease, the other comorbidity that seems to be a particular risk factor is hypertension, high blood pressure. So people with these conditions are more prone to the disease at any age.
Okay, so it's not just respiratory diseases, it's things like diabetes and heart disease that can hurt you as well. That surprised me. I thought it might go for the respiratory system. Is that because if pneumonia sets in, then it's going to be anything that could potentially kill you?
Yes. I think these people are generally weaker altogether, physiologically speaking. But with high blood pressure, there may be something to do with the receptors that the virus fits into. So in the respiratory tract, there are receptors called ACE2 receptors, and the virus binds into those ACE2 receptors. That's how the virus gets into the cells of the body. And these ACE2 things are to do with blood pressure physiology. So there may be some complicated things going on there that I certainly don't fully understand at the moment. But for example, if someone has heart disease, especially if they have congestive heart disease, the blood's not going through the heart as well as it did. That means there's a backlog of the blood. There can be a backlog of the blood into the lungs, and that can increase the amount of fluid that accumulates in the lungs. That's called pulmonary edema, and that can contribute towards things like pneumonia. So it's whole system physiology, really, whole body physiology. And likewise with diabetes, it depends how well probably the diabetes is controlled. So if the diabetes is poorly controlled, the sugars in the blood will rise. That means the sugars in the tissue fluids also rise. And the white cells, the immunological cells that normally move through the tissue fluid to attack viruses and bacteria, aren't able to migrate as well in sugary environments.
Wow.
So what we're seeing is that all these diseases will increase the risk of, not so much the risk of contracting the disease in the first place, but the risk of getting severe or critical disease as a response to the virus, as the body fails to physiologically combat the virus. But no one has yet picked apart whether it is intrinsically these things or whether it's the increasing age. But we do know that the two are going together. So at the moment, I think I would have to conclude that comorbidities increase the risk of severe and critical disease, and age increases the risk of severe and critical disease. And someone who is old and has comorbidities, it would be reasonable to assume, has a much greater risk of serious disease and comorbid and critical disease.
Now, I know you said to anybody who's smoking out there to stop smoking. And we're also seeing potentially that obesity is not going to help this as well. And maybe A, you could talk about that, but B, I mean, if you actually started controlling your diet, do you think that's would actually give yourself a chance of avoiding this disease? And we know, and from my country in America, I mean, it's a massive problem. You know, you have 40% of the population that's obese. I mean, this could really make a factor in taking a lot of lives.
Yeah, let's take those two in turn. Should we take smoking first?
Yes, please.
So in China, the case fatality rate was significantly higher in men than in women.
Like how much? 70%?
Yeah, probably getting on for twice as many men as women died, roughly. I can't give you an exact figure, but it's kind of.
I think I saw the numbers you ran recently.
Yeah, it's like a significant difference.
Male,
it was. I think
female.
In the UK it was like 1.8 versus 3.4 case fatality rate. So it's probably getting on for double the amount of men, roughly. So initially we thought that there might be a lot of problems in China because there's a lot of atmospheric pollution in China. But it's reasonable to assume that will probably affect men and women roughly in a similar way. But in China, men smoke quite a lot. There's quite a lot of male smoking in China. But in Chinese culture, it's considered a bit impolite for women to smoke. So the prevalence of female smoking in China is much less. And also in the Italian situation, part of the problem there might be, I can't give you official figures on this, but anecdotally, certainly when I was in Italy, everyone seemed to be smoking. And I've had emails from quite a few people in Italy saying that smoking is pretty prevalent in Italy. And again, I think it probably is more prevalent in men than women. In my country, historically, smoking has been more common in men than women, although that's probably not the case now. So physiologically, it makes perfect sense because smoking, and I think this applies to cannabis smoke, wood smoke, cigarette smoke, any sort of smoke, the cilia that normally waft up the mucus from the lungs are inhibited by the smoke. So if the cilia aren't as motile, then the mucus is going to accumulate in the lung fields. And that's going to reduce the clearance of the virus, which means the virus has got more time to hang around in the lower respiratory tract, making it more likely the virus is going to infect these susceptible cells in the lower respiratory tract with the ACE2 receptors. So there's no real question in my mind that smoking is a risk factor for all respiratory disease. I mean, you don't have to be anything. Everyone knows that, really. And specifically for this virus, though, it does seem to be a particular risk factor.
And maybe while we're on that, maybe we can talk about how this actually attacks you, because it goes into the respiratory tracts and it ends up in pneumonia, which ends up in lungs not functioning and death. Is that right?
Yeah. So what happens is the virus goes into the lower respiratory tract, and it'll cause, in the cells of the lower respiratory tract, it will get into those cells. And the reason it gets into those cells is that is the only place in the whole wide world that I know of that the virus can reproduce. So the virus can only reproduce in specific human cells that have this ACE2 receptor on their surface. Now, there probably are other cells with ACE2 receptors within the body, but of course, the virus isn't going to access those initially because you breathe it into your lungs. So the virus gets into these cells in the lower respiratory tract. In those cells, it multiplies. Now, viruses are absolute scallywags. What they do is they hijack the cell's own genetic apparatus that the cell normally uses to synthesize its own proteins, and forces the cell to produce new viral proteins. These are then constructed into new viral particles with new RNA in them, and these then bud from the surface of the infected cell, probably thousands of them from an infected cell. And because these cells are lining the respiratory passages, these viruses go into the respiratory passages, into the mucus. Then, of course, you breathe, you cough, you sneeze, and they come from the mucus out into the air, and we get this droplet infection effect. And that can go directly from person to person, which is why we want 2 meters distance. Or it can, if I'm an infected person, for example, and I cough onto a surface, you then touch that surface, the virus goes onto your hands, then the virus can go into your mucous membranes in your mouth, your nose, or your eyes, and infect you that way, because from your eyes, your mouth, or your nose, it will go down into the respiratory tract from there. Now, once it's in there, what happens is the viruses in the cells actually change the biochemistry of the cell, and viral proteins are shed or excreted, if you like, onto the surface of the infected cell. Now, as a result of that, the specialized immune cells called T killer cells, or NK, natural killer cells, they've got a great name. They're just natural killers. And these kill the infected cells. But of course, when they're killing the infected cells, they're causing quite a lot of inflammation at the same time. And that causes swelling in the airways. But it's quite a clever strategy because it kills a lot of the viruses. So the analogy I used to use with my students is it's like throwing a hand grenade into a room full of terrorists. You take out the room, but you take out all the terrorists in the room as well. So these natural killer cells, by killing the virally infected respiratory lining, the respiratory epithelial cell, kill a whole load of viruses, but then they leave inflammation. And that inflammation causes swelling. So the airways can swell. And if the airways swell, they kind of squeeze in the way. So that means you've got less space through which the air can go. So people can feel quite short of breath. And often people do feel short of breath with this illness, but that doesn't necessarily mean they're going to develop severe complications. So the severe complications, the people that become critical, what happens is the virus actually gets down into the very bottom of the air sacs, the alveoli, these microscopic air sacs where the oxygen gets in and the carbon dioxide gets out. And they cause inflammation in there. And that inflammation causes the production of fluid which seeps into the alveoli. So instead of having an air sac which is hollow and full of nice fresh air that you've just breathed in, it's full of inflammatory fluids. And that's called ARDS, Acute Respiratory Distress Syndrome. So a lot of these patients that are critical get acute respiratory distress syndrome. That's the inflammatory effect of the virus. But as well as that, when these cells that line the respiratory epithelium are damaged, basically, instead of having a nice smooth layer of mucus with a nice smooth layer of columnar ciliated epithelial cells lining your airway, what you've got is big holes. It's like someone's taken a few teeth out, you've got big gaps. And bacteria get into those gaps. And you can get bacterial secondary infection, and that can lead to bacterial pneumonia as well, where again the alveoli fill up with fluids. So if we take a pandemic like the 1918-1919 pandemic, there's been some fascinating studies there. That was an influenza A. It was an influenza virus. It wasn't a coronavirus. But recently, there's some fascinating videos on YouTube about this, where people have gone up to the permafrost, for example, and exhumed bodies of people that died from that condition in 1918, 1919. And they've analyzed the virus and they've found the genetics of this H1N1 influenza virus in those people, confirming that diagnosis. But they've also found that quite a few of them did develop secondary bacterial pneumonia as well. Now, we can't kill the virus at the moment any more than we could in 1918. But of course, we can kill the bacterial secondary infection. And that's where the supportive treatment becomes so important as we monitor these patients, make sure the blood oxygenations are adequate, monitor their chest x-rays, see how much of the lungs are filling up with fluid, and treat them accordingly.
Okay, so when you say support, that means give them antibiotics and put them on ventilators. Is that what you kind of have to do at that stage of the disease?
You only put someone on a ventilator if they were critical. Now, there could be a lot more people would be at risk of secondary bacterial infection. In fact, it would be reasonable for anyone who was severe to have antibiotics to prevent bacterial secondary infection. And this is something that doctors often do. So some doctors will prescribe prophylactic antibiotics for a severe respiratory infection. Others will say, no, we'll wait until the signs of bacterial secondary infection. And we do know that because we can tell that from blood tests, whether there's bacteria present. So personally, I would prefer to wait because I don't like giving out too many unnecessary antibiotics. But we could treat those infections very effectively. But then, of course, they would have no effect on the virus itself. The ventilation is if we need to... What happens with the ventilation is that there's fluid collecting in these air sacs, the alveoli. And what you need to do is like keep a constant pressure in the alveoli so that the fluids are pushed back into the blood. So you keep some fresh air in the alveoli. And with ventilation, what you can do is leave positive end pressure in the alveoli when someone's breathed out. You can control the pressures as the air goes in and out of the lungs quite precisely. And you can maintain oxygenation of the blood by keeping the fluid out of the alveoli for a period of time. Then you do that for a period of time, and what you hope is that the body's immune system will develop, the body's own natural immunity will then get rid of the virus. When we get rid of the virus, the inflammation and the acute respiratory distress syndrome should resolve, and we hope that these patients will make a recovery.
Okay, but we need enough ventilators to do that, and that seems to be the bottleneck everyone's talking about, because
we do. But if you or I, Brian, went into an intensive care unit now, being healthy, and were ventilated for a week, the risks of us developing some complication are quite significant. Ventilation is not a casual procedure. It's associated with a quite significant risks of its own. It's very much a last resort. And you're right, we need ventilators. But when someone's on a ventilator, you need an ITU nurse who's experienced with ventilators looking after them. You need ideally an intensivist to look after the patient's biochemistry. You ideally need an anaesthetist to look after the patient's oxygenation and airway. So for ventilation, for example, someone would either need an endotracheal tube or a tracheostomy tube to be able to breathe into their lungs. To tolerate that, you would need sedation. Very often you need muscle relaxation so the patient's muscles aren't fighting the ventilator. And for that you need syringe drivers, you need the right beds, you just need a whole host. It's the whole host of really quite complicated care as well as the ventilator. So you're right, we haven't got enough ventilators, but we actually need more than ventilators. We need a lot of drugs. We need a lot of syringe drivers. We need a lot of specialist nurses and doctors as well. So, and at the moment, we just probably got enough.
And so are we kind of missing the point when you see, I mean, because now General Motors in America is offered to make ventilators, and we're talking, I think I've heard realistically they're not going to be ready till June, but that's not necessarily the bottleneck. It could be all of the staff and the drugs and the beds and everything else. So that's not necessarily a solution in itself.
Any bottleneck you can get rid of it. So,
okay.
The ventilators absolutely would be a bottleneck. So if we can have plenty of ventilators, then that is going to be a massively good thing. And we need an awful lot more than we've got, potentially. It depends how effective our preventative strategies are.
Okay.
So rather than, we need to get ready, of course, flat out, more ventilators, more training, absolutely everything. But to me, even more critical is that we slow this pandemic down. We need to really, really slow it down.
How do we do that?
Well, there's two ways to do that. There's the bottom down, and there's the top down and the bottom up.
Do you have your Grey's Anatomy book there, John? Because you have a great, if you don't, that's fine, but maybe you could just use your hands. That's okay. But
I do have my Grey's Anatomy book, Brian.
Okay, good. So explain this analogy maybe to everybody here, what you mean, because I think it's really good.
So what we have is the top-down approach is pressing down on it like that. So try and get the numbers down like that to try and flatten this curve. Now that is your social distancing. That is removing the opportunity of the virus to spread from person to person. So It's isolating households. It's not going in crowded trains. It's keeping 2 meters away from everyone. In fact, it's doing everything now that we are doing in the UK.
And you have a phrase which you say, 2 meters distance determines our existence.
That's right. Yeah, a friend of mine coined that. I can't take credit for it, but yeah, 2 meters distance determines that. Well, what we try and do in this series is have reliable phrases that people can learn.
And so your book kind of represents where we are with the disease, pushing the top down.
This is the burden of the pandemic.
Okay.
It's heavy. But we need to get it down by these social isolation measures. But we also need to pick away at it from the bottom. And the way we pick away at it from the bottom is by testing. So we need to test. And ideally, everyone who has this condition should be diagnosed so we know who's got it. And at the moment, we really don't have the testing. Now, in my country, the testing is being stepped up, and in the States it is as well. But basically, quite a few places in the world did not get their act together on testing. I think what happened in the States was the CDC decided to make their own test, whereas other countries just imported the standard World Health Organization test. And I think the CDC didn't produce it quite as quickly as they thought they were going to. So, and that's what we were talking about before, Brian, where this community spread had already developed before the cases were officially recognized and diagnosed. And that gave time for this momentum of cases, this community cluster of cases to build up.
Right.
So
now, one place
from the bottom. Sorry, Brian.
Right, and that's picking away from the bottom. Now in Asia, we saw them deploy a massive amount of testing early on. We know they did it in Singapore. We know they did it in South Korea. I'm pretty sure they did it in China as well. Now, they were prepared before because SARS hit them harder than everyone else. So I think they were prepared, whereas it never really hit America. And so I think America was more blasé about it. Am I stating that correctly? Because I'm understanding in South Korea, they tested everyone and then isolated the cases and investigated the cases, and through mobile technology tracking people and also mobile alerts, really got the whole population on board to all act together to really squash and drop that R naught down below 1. That's what they're trying to do, right?
Exactly so, Brian. Yeah, I think you've identified two issues there. The first one is people in the States and in Europe had no concept of pandemic. If you'd said, what is a pandemic? They might have been able to write a definition down on a blackboard or something. But, to actually know what a pandemic means, to actually understand the devastating effect that a pandemic would have, because people couldn't conceptualize that they thought it couldn't happen, because it's unimaginable. So they believed it wouldn't happen because it was unimaginable. So I think that's one problem there. But you rightly say, as you rightly describe, there's been two main strategies that have been proved to work. So in China, initially they had massive top-down strategies with the social isolation to try and press the book down.
Right, in almost a military way that maybe only the Chinese population would tolerate, where they were literally locking things down and forcing people to whatever, quarantine or that kind of thing.
Yeah, basically isolating every person from every other person. Now, you're right, the Chinese are a very disciplined culture. But in my country now, in England now, we're doing exactly the same thing.
Yeah.
And we have had a few hiccups yesterday. We saw some crowded tube trains and things like that yesterday, but people are realizing, and certainly where I am, people understand that this is a matter of life or death. We simply have to do it. So the population is now complying with that. And then as time went on in China, they did start introducing more testing, but the virus got a bit of a head start in China. It was really bad timing. It was Chinese New Year.
Yeah, and the New York Times had a whole graphic showing the travel and the population, and the fact that in Wuhan, I think on January 1st, 7 million people left Wuhan for the Chinese New Year after they believed there were probably 1,000 cases perhaps, and went to all areas of China, and then potentially some of those people went to Thailand, and you could see, like you said, bad timing and not enough early awareness there.
Yeah. So, for example, one went from Peking to Singapore, met someone from my country in Singapore. The person from my country flew back to France, infected a few people in the chalet, then flew back to south of England somewhere and affected a few more people in a pub. So yes, that definitely happened. What actually happens is you start off getting individual cases, then you start off with clusters, and then you develop onto community spread. So quite a lot of those early cases were able to contain at the individual cases stage before they developed into clusters. But as you rightly say, the Chinese developed a lot of testing as well. And the other thing the Chinese did was they used a lot of technology. So in China, people often live in compounds or a particular block of flats, and very often there's a shop and maybe a hairdresser's and things associated with that. It's almost like mini communities within the city. So what they did in China was they basically fenced off these mini communities of maybe several hundred people. And everyone was given a card, and they had to scan in, they had to scan out. They were only allowed out to go to the supermarket for shopping. They scanned out, they would have their temperature checked on the way out, they'd go to the supermarket, they'd have the temperature checked on the way into the supermarket, they'd scan back in, and this was all controlled. And later on, it all went on to mobile phones as well. So people were, whether people were allowed to travel or not depended on the rating they had on their mobile phone. So their behavior will give them a traffic lights that I've red for absolutely not, an amber for maybe in a few days' time, and a green for yes, it's okay. So everyone had like a health traffic light system on their mobile phone. A lot of technology was used. And as you rightly say, Brian, the very similar approach in Korea. Now, the shutdowns in Korea were nothing like as draconian as the ones were in China. The Koreans went for much more a lot of testing. So the Koreans mobilized a lot of test kits. They did a lot of testing. When someone tested positive, they were isolated, and the contacts of the person who tested positive were quarantined. So they were very precise and surgical. You know, this picking away from the bottom, the picking out the individual cases. So the Koreans were very good at that. And they also used a lot of mobile phone tracking as well. And mobile phones to scan in and out, and mobile phones for all sorts of things I don't pretend to understand. But it was very technologically controlled. So one person might have a fair degree of freedom because their electronic devices said they were very low risk. Whereas other people, if their electronic device said they were high risk, then they'd be quarantined for 14 days. So the Chinese approach was a bit sledgehammerish from on top, although they did start doing the testing as well. Whereas the Korean one was much more precise, testing and isolating every case. And as you rightly say, they used the strategy of both of those in Hong Kong and also in Singapore.
Right. Now, let me ask you, John, are either one of those options viable for the UK and the US now, or is it gone too big to where there's just too many cases we don't know about in too many areas?
No, they're both viable, Brian. We can't give in to this virus. If we give in to this virus, a lot of people are going to die. We have to fight. I really believe we have to fight this all the way. And the only way to do it is to use both. Now, what you can do is this top-down suppressing strategy. You can implement that straight away by edict. So my prime minister goes on telly and says, right, from tomorrow, no one goes out. So that's it, no one goes out. You can implement that straight away, that you can legally mandate people's behavior. And people will comply with that because they know it's necessary. You know, one of our sayings is healthcare is of the people, for the people, by the people. You know, we realize this is for us, and we realize that we are the ones that have to do it. So that can be mandated straight away. Now, a couple of days ago, our Prime Minister said, we're ordering millions of tests. And I thought, that's really good. He's got it now. He really understands that now, because that means we can attack it from the bottom as well. And we absolutely need both. So the thing is about this lockdown strategy, we need to implement this now because we can do it just by edict. And that gives us a few days or a couple of weeks to get millions of testing kits. So we can start this precise, more surgical resection of the infected cases out of society. And as well as that, there's going to be two sorts of testing, you probably realize. There's what we call antigen testing, which is testing for the presence of the virus itself. So you'll actually test for a person who's incubating or actually has the disease. And then there will be antibody testing, also a different type of test. Now, the antibody is the immune protein or the immunoglobulin that the body makes in response to the presence of the virus. And we think that will be in the blood for a year, probably 10 years, and probably for life. But we're not nearly always talking about years that's detectable for. So
what's the difference between the two tests? Why are those both important?
They're both important because the antigen test tells you who's actually got the disease. And that means you can isolate them straight away. And that means you can quarantine their contacts straight away. And it also means you can monitor them to see the condition and to see if they're going to deteriorate or, like most people, make a relatively mild course and a relatively quick recovery. So we need that clinical information to diagnose for them and those round about them. And of course, that's going to prevent the next door neighbor or their workmates contracting it. So we need to know that, but we also need to know the antibody test so we can see where this disease has been. two real reasons for that. The first one is, suppose I get an antibody test and I am positive for COVID-19 antibodies. Now, that means I am almost certainly immune to this particular strain of virus. So I can go back to work. It's safe for me to work in an intensive care unit or an accident and emergency department, looking after people with the infection, because I'm now immune to that infection.
Right. I've heard about that it could also mutate in the future. Does that mean I wouldn't be immune if there was a mutation, or does that also take time for that to happen?
It's a very good question, Brian.
Okay.
Mutations can be genetic shift or genetic drift. Now, there's always genetic drift. So there's minor changes that go on in the virus all the time. RNA viruses are always mutating. But at the moment, the people that are developing the vaccines believe that the genetic drifting in the virus is not sufficient to alter the virus so much that one vaccine for all of the world will not be possible.
To continue watching the rest of the episode for free, visit our website londonreal.tv or click the link in the description below.